Good afternoon and welcome to Facebook Live with Holy Cross Health. My name is Brenton Andrasic, Manager of Physician Alignment and Business Development at Holy Cross Health. Before we begin, I'd like to call your attention to a few ground rules that you'll see in the comments section. We encourage you to participate, but please keep any questions and comments general. We won't be discussing anyone's specific health situation in this public forum. If we can't get to every question today, we'll provide additional feedback through Holy Cross Health's blog, or we can connect with you one-on-one through our program channels by phone or website. For those of you joining us today on Facebook, we thank you for being here and for taking an active role in your health, and we at Holy Cross are happy to be your partner in your health journey. Today we're here with Dr. Zohair Alam, Medical Director of the Joint Center at Holy Cross Hospital, and Laura Collins, Orthopedic Surgery Program Coordinator for Holy Cross Health. Dr. Alam, a practicing orthopedic surgeon, and Laura, a doctor of physical therapy, are integral members of the joint surgery team at Holy Cross Health. So, Dr. Alam, I'd like to start with you. We're going to start off broad and work our way to more specifics. Could you just tell us what are some of the main causes of joint pain?
Sure. A lot of joint pain happens from some type of cartilage disorder in the joint. This can be due to some type of long-standing injury or even normal wear and tear, or it can be due to some type of abnormal alignment of the joints. Many people know the terms knock-kneed and bow-legged. So any type of abnormal alignment or force or injury can cause the cartilage to slowly wear away and then end up causing arthritis.
And could you tell us what are some of the risk factors for joint pain?
Yes, one of the largest risk factors right now is obesity or being overweight, the lack of activity, some type of previous injury or some type of deformity. They all lead to a higher chance of getting arthritis in your hip or your knee.
And so you'll see that as we go along, viewers had the opportunity to submit questions when they pre-registered. So we'll be periodically including some of those questions as we move through today's discussion. So here's one of those questions. Dr. Alam, I'll address it to you as well. Someone asked, does joint pain come with menopause?
So during menopause, hormonal changes happen. So that can affect the body in the sense that weight can change, the stability or flexibility of ligaments can change, soft tissues can become more or less inflamed. So when you put all of those things together, it can have this like indirect effect, which can flare up joints that already have arthritis in them.
So Laura, I'd like to turn to you. What is considered chronic pain?
So I believe chronic pain is pain that has lasted longer than 3 months, 6 months, even a year. Would you say, Dr. Allen?
Yes. Everybody's definition is a little bit different, but medically we always say it's at least 3 months of pain.
And so whether someone has acute joint pain or chronic joint pain, someone comes into the office. Laura, I'll direct this to you, and Dr. Allen, feel free to jump in as well. Can you just walk us through the diagnosis process? How does someone go from coming in with an issue to actually getting a diagnosis?
So I'm actually going to punt that
Sure.
to Dr. Allen because he's the first line they usually go to. Yeah.
Many times we're the first line. Sometimes they do see the therapist first, but in general, the pain or swelling or limited motion is what brings people in. Some people will try medicine or something at home like ibuprofen or Tylenol, and if that doesn't work for a few days, then they make an appointment to see their doctor, sometimes somebody like me, an orthopedic surgeon directly, or sometimes their primary care doctor. But by the time they come to us, we're asking them what prompted the visit to the specialist. We'll most likely get some x-rays to look at the joint itself to see if the joint surfaces have worn away or if they're down to bone-on-bone arthritis. We definitely examine them to see how weak or stiff the joint is. And then we can discuss different treatment options with them.
And one thing that patients often want to know about is how much is this going to cost? So does insurance typically cover the cost of an evaluation and diagnosis for joint pain?
Yes, and that's always a difficult topic because everybody's insurance plan is a little different. People have sometimes copays or deductibles, so that's a very specific question that will depend on each person's plan. But in general, yes, an evaluation or treatment will be covered by insurance, whether that's going to see the doctor in the office, getting an injection, any prescriptions, or seeing somebody for physical therapy, right? Yeah.
All right, great. And so we've talked a little bit about some of the causes. We've talked a little bit about how you might get a diagnosis. And so, we're going to spend quite a bit of time, and we'll see what kind of questions roll in as well, but talking about treatment options. I think that's probably what people would like to hear about most. And judging by the questions that we received in advance, it seems like there's a lot of interest in treatment options. So, Laura, we'll start with you. So obviously there are surgical treatments, and we'll get to that, but let's talk about some of the non-surgical treatment options that are available for joint pain, and especially thinking about those options that are available right here at Holy Cross.
Sure. So people can actually go on to holycrosshealth.org and look at what we offer. We have joint pages that talk about managing joint pain and what we offer. We have a physical medicine department here at Holy Cross in Silver Spring. We also have a pain management department here at Silver Spring. So those are two conservative options where patients can come in and seek pain relief and restore function and see, if that's going to help solve the problem.
Yeah, I've also seen patients sign up for like senior fit classes and other classes that the hospital offers, and they use those as well.
Right.
Yeah.
And what are some of the other types of therapy that people might be able to try, before they get to the stage of requiring surgery? I'm thinking people ask questions about supplements, about creams and lotions, and of course about physical therapy. If you could just elaborate a little bit more upon that, because people really seem to be interested in those types of, in some cases, alternative therapies.
So I know in therapy sometimes you all use biofreeze.
Yes.
To help
Yes.
make the joint feel less inflamed,
Yes.
right? So biofreeze is a very common one. There are all sorts of over-the-counter topical creams you can use. There's a very good one called Voltaren gel or diclofenac gel. That recently became over-the-counter, so you don't need a prescription for that. And then typically we'll try things like Tylenol and ibuprofen, which is Advil or Motrin, or Aleve, which is naproxen. And in my practice, we tell most people go ahead and try the over-the-counter versions first, because that helps most people. And if that's not helping, we can always prescribe a higher dose of some similar type of medication. The problem with arthritis is, in order for those medicines to work, you have to take them very regularly. Unlike a headache where you can take a Motrin or a Tylenol and it's gone in an hour, for this type of condition, you do need to take it, if not every day, very regularly. And if that's not helping, especially with the knee, we'll move on to things like a cortisone shot, or known as a steroid shot, or a corticosteroid injection. It's more common in the knee. We don't do it as often in the hip because it doesn't work as well. But many patients can do very well with these injections. And as long as you wait at least 3 or 4 months between injections, you can get them over time more than once. And in those people where those don't help, we can always try the viscous gel injections that are known as hyaluronic acid injections. They're known by different names on the market, but they're supposed to cushion and lubricate the joint. They're not going to replace the cartilage, but they're at least going to make the pain less. And in the perfect scenario, that can work anywhere from 6 to 12 months at a time.
So that's a lot of really great information there. Thank you, Dr. Alam, and thank you, Laura, as well. We also had some people inquire about platelet-rich plasma therapy. Could you just talk a little bit about that and when it might be used?
Sure. Platelet-rich plasma is the portion of your blood that has the more liquid part of the blood with the platelets and all the factors that are supposed to help things heal and reduce inflammation. So in acute injury situations, it's very handy and does improve recovery. In the cases of arthritis, the jury is still out on that because there's no long-term studies that really show if it works really well in the long term. And then there is a process for doing it, which takes several steps in an office or a clinic setting. And then insurance may not cover it in most cases. So if a patient is interested in doing it, they have to be ready to pay whatever the provider is charging for that service.
And so before we move on from non-surgical treatments, I do just want to make sure that we really give some time to physical therapy.
Thank you.
So Laura, would you mind just telling us a little bit more? We've mentioned it already, but for those who might not be familiar with it, what is it? How does it work? What do you actually do when you go in to get physical therapy? How long might you get it? All of those sorts of details.
So physical therapy, typically we'll get referrals from orthopedic surgeons, neurosurgeons, primary care providers, and we treat musculoskeletal injury, disease, anything that affects the patient's strength, ability to move, and obviously pain. So we work with assessing you, obviously, determining, what was the cause? Was this a traumatic injury? Did you have a fall? Is it chronic? Is it arthritis? And then we have a treatment plan. So we look at using therapeutic exercise, maybe modalities. We use obviously heat and ice. We use electrotherapy. We use dynamic splinting, ultrasound, even dry needling has come into vogue with what we do. And so what we want to do is restore function. We want to reduce pain. We want to see are there structures that are tight or weak, and we address those. So that's our goal. And obviously we want you to be safe as well. So if you're really having a lot of issues with pain, that can put you at risk for falling. We might have to, prescribe an assistive device while you're trying to get stronger and heal. And sometimes we recommend bracing or compression to try and, keep you on your feet and keep you moving.
So if I may add that physical therapy is, a first-line treatment we do prescribe out of the office. And a lot of patients, once they've done a few weeks of it, they notice the strength's returning and the motion's returning. And their pain, while it's still there, it does feel better. If there's, an okay way to say that there's a good pain, it does decrease.
Absolutely.
And then they start to feel more functional and a little more confident about their physical well-being.
That's great. So before we move on to surgery, we did get a viewer question live out there on Facebook. So we've already covered some of this, but part of it we haven't. Someone asked if there's any non-surgical therapies that you recommend: drugs, CBD, oral, or creams, etc. So we haven't really talked about CBD. If you'd like to comment on that.
So CBD is the non-addictive component of marijuana. You can buy it obviously by itself, and I have patients who do try it. It's had mixed results, but I feel that there are a few people who have tried basically everything and nothing has helped, and then they try it and it does seem to offer some relief. So my advice would be is if you've tried everything else and you're still trying to find something that might work, I think it's reasonable to try it.
All right, so we've talked a lot about non-surgical therapies here, so I would like to move on to surgery, as oftentimes the step that you take after you've gone through some of these non-surgical modalities. So Dr. Alam, in a nutshell, when is it time to consider surgery for joint pain?
So the best time is when the patient feels ready, meaning if a doctor recommends it, you should trust their judgment. If your family is telling you, hey, I think you should think about joint replacement, sure, listen to them, but only do it when you feel ready. We've talked about physical therapy, and a large component of recovering from joint replacement is being willing and ready to do the physical therapy, because I think that makes the success of the surgery, stand out remarkably. But when you've tried all the things we've discussed and you just feel like you're at your wit's end and you're just it's affecting things you do in your everyday life, things you want to do or have to do, then it's time to seriously talk to your surgeon about that.
So in terms of the types of surgery that are available to patients, could you talk a little bit about the different types of surgeries and, specifically thinking about the difference between an arthroscopy versus a partial joint replacement and total joint replacement?
Sure. Arthroscopy is, in its true sense, never done for arthritis. Arthroscopy is the surgery where you look into in this case, the knee through small incisions with a camera, and you can treat issues like meniscus tears or other soft tissue injuries like that. While you're there, we can check the joint and see if there's arthritis or not, but there's no direct role for arthroscopy in treating arthritis. It's mainly to treat meniscus tears. So to definitively treat arthritis, you do have to consider some type of joint replacement. The knee itself has three main parts or three main compartments. And when we do a total knee replacement, all three areas are getting replaced or resurfaced. So a partial replacement is where only one of the three compartments is getting replaced. So there are a few people who have worn down cartilage just in one part of their knee, and they may be candidates for partial replacements. The criteria to be eligible for that medically or surgically is more strict. You have to be of a certain weight, a certain age. Your knee can't have more than a certain amount of deformity to have a successful partial replacement. Because sometimes if a patient gets a partial and there is arthritis in the other two parts of the knee, then eventually it's going to have to be converted to a total replacement anyway. So for most people, considering a total knee replacement is usually the way to go.
So, Dr. Allen, we got lots of great viewer questions in the pre-registration, so I'd like to just run through a few of those if we could. Someone asked, are the incisions for total knee replacement small?
So the incision for a total knee replacement is directly on the front of the knee. We call it an anterior midline incision, and it's going to be based on the size of the leg itself. I tell patients we're going to make the incision as small as we can, but we're going to make it as large as we need to so we have enough exposure so we can see everything, make sure we like where all the implants have been placed, and that we're not missing something else that needs to be treated. Sometimes when you try to do surgery through a very small incision, you end up traumatizing the skin so much that while you may have accomplished your goal with the surgery, then you're concerned about having a problem with the wound healing. So clearly with any surgery, you want the wound to heal without any problem. So the general principle of making the incision a little larger but having less stress on the wound is usually the way to go.
We also had a few questions in this vein, but someone asked, is knee replacement surgery required if there's no cartilage and only bone on bone, or are there other treatments available?
So if somebody's knee is by definition bone on bone, which means all the cartilage is gone and there's no joint space left, again, if the patient's symptoms are bad enough and can't be managed with all the other things we've discussed, then knee replacement really does become an option for them.
So a couple other interesting questions here. One person, actually several people asked similar questions to this. If they have multiple joints that need repair or replacement. So one person said, I have both the shoulder and knee that need replacement. Which surgery should I do first, and how long should I wait between surgeries?
That's always a good question, and again, the answer depends on the individual. My first response would be get the joint replaced that hurts the most. But if it's a toss-up, then maybe getting the shoulder done first so that feels comfortable will help, so that when you get your knee replaced and initially when you're using a walker or a cane, then your shoulder won't hurt as bad. But I would always say whatever joint hurts the most, get that replaced first.
Sure, that makes a lot of sense.
Laura, what do you think from a PT standpoint?
So I would definitely echo that, but I would also say if that knee's bad and they're at risk for falling,
That's a
maybe
good point.
consider, and if they can use their arms for walker support, because they're going to need to be able to use their upper body to support during recovery. So I think, looking at kind of the whole picture, like, okay, what's the worst, but what
Right.
can we do to really get you through recovery of each of those surgeries safely? So
That's a good perspective from a therapist.
Absolutely.
Sorry.
That's good. I like it.
Right? That's part of the program. You get the whole perspective with this
Exactly.
program. Exactly right. So some folks also want to know if there's anything that would stop someone from being qualified for joint replacement surgery.
So you have to look at it two different ways. Number one, if medically the patient has some type of cardiac or heart or lung condition or liver condition that would make surgery unsafe, that would probably be the biggest thing not to let them have surgery. If they're a smoker, a lot of surgeons will hesitate to operate on smokers because we know that their wounds can have problems, and we've all seen that in practice. So that is like a partial disqualifier. But if somebody stops smoking and otherwise has healthy tissues, then they can become candidates. Or if there's some type of issue with the skin or some previous trauma that has really threatened the skin itself, those type of things would disqualify somebody from surgery.
So I just wanted to get in a couple questions that we got in as we were talking related to things that we talked about earlier. So one person asked, what was the needle therapy that cushioned the joint?
So that's called hyaluronic acid injections. Hyaluronic acid is it's a part of our normal cartilage that helps cushion the joint. So there's different brands out there. One brand is called Synvisc. I think that's the original brand. It was derived from the comb of roosters, so some people know that as the chicken shot. And then there are a bunch of different brands out there that are basically the same thing. They're just probably a little different formulation. But that's the main hyaluronic acid injection.
And we did mention meniscus tears previously, and so someone asked, what if the meniscus tears are extremely old?
So if the tears are old, then it's very likely, or very highly likely, that there's also arthritis in the joint. So if the arthritis is already in the joint, then treating the meniscus by itself won't really help the whole situation.
So while we're talking about surgeries, Laura, as our program coordinator for all of Holy Cross Health, could you tell us a little bit about how Holy Cross has approached COVID testing when it comes to our surgical patients?
So during the pandemic, we were able to continue surgery. There was a time that we stopped, but we were able to continue and restart surgery in May. Obviously, safety is our top priority. It's one of our core values at Holy Cross. And so how did we approach that? We obviously followed Governor Hogan's executive orders. We followed Maryland and state guidelines, and then we worked within that. So we COVID tested everyone that was coming in for elective surgery. We follow the screening precautions. If anyone coming into the hospital, including colleagues, doctors, anybody coming to the hospital had to be screened. They had temperature regulations, and everybody has to wear masks. We have COVID-free units. Obviously, our joint unit is one of those COVID-free units, as well as our recovery unit and our OR. So that's how we process during this time,
Right.
which, it's been extraordinary to be a part of and be witnessing, how we all came together to be able to make that happen.
Yeah, I'd say the hospital adapted very quickly to the whole pandemic, and when we did start operating again, we were able to, resume the total joint replacement program, and we were able to send patients home the same day, or the very next day, in a safe fashion, and patients did very well.
It really has been an extraordinary time for all of us here at Holy Cross, and of course everyone in the community as well. I'd like to talk a little bit more about surgery before we move on. So, Dr. Alam, Holy Cross now offers joint replacement surgery using the ROSA robot system. Could you just tell us a little bit more about robotic surgery and who could benefit from this type of procedure?
Sure, robotic surgery has become more common. It's been around for non-orthopedic surgery for a while, and in the past few years, it's found its place in orthopedics. We're using it here at Holy Cross for knee replacement. Eventually, we'll be using it for hip replacement and shoulder replacement when the time comes. It helps the surgeon be more precise. So for those of you who may have had a joint replaced without a navigation robot, don't feel bad that you got a inferior product. You did not, but it just ensures that the surgery we do is to the expectations that we as a surgeon and as you as a patient want. I did one this morning. I did the patient's previous knee without the robot last year, and she did fine. So she was ready to have this knee done, and she had a knock knee or a valgus knee. So with the robot, I was able to preserve bone and get the alignment I wanted, and make her knee as stable as it needed to be, and she'll also do very well with this side. So it's really allowed the surgeons to become more precise and get some good data about the surgeries.
So, and obviously amazing stuff. I'd just like to point out as well that the ROSA robot system is available at Holy Cross Hospital in Silver Spring, as well as at Holy Cross Germantown Hospital. So let's say that the patient and their physician have decided the surgery makes the most sense for them. Laura, can you walk me through what I could expect as a patient in the process leading up to surgery?
Sure. So we have a lot of resources for you to help you prepare for surgery. We do require that you attend our pre-op joint replacement class. During this time, we were able to convert to virtual classes. We used to have you come onto campus and be able to meet you individually, but we are now able to touch you through using WebEx and virtual, and we also have a pre-recorded class that lives on our website. We have a joint guide compendium book that you can download and use as well. And so the class is really about getting you prepared for surgery, what surgery looks like, and then recovery from surgery, and making sure that you have everything in place to have great success.
Yeah, what patients have said to me, especially about classes, they get to virtually now see some of the people who are going to directly take care of them.
Yeah.
So when they get to the hospital or meet the therapist or meet the nurses, they have a friendly face that they already recognize, and it's taken out a lot of the apprehension that they normally would have before surgery. So, it starts in the office with scheduling surgery, scheduling the date, because then your medical lab tests and history and physical and other things have to be done based on what date you pick. And then you attend class as well. So we do make it a requirement because we have found that over time, the patients who are most satisfied with the whole process are the ones who went to class.
So we just got a interesting question in. Dr. Allen, I'll address this to you. Do you do bilateral knee replacement via the robot simultaneously?
So it's very rare that we do it in general, even without the robot. There's a little higher chance of some medical complications after surgery. So we do it mainly if somebody is in a scenario where, number one, they're overall healthy. Number two, the overall deformity of in the case, the knees is not that much. And there's some real good reason why, like, let's say they only have this summer to get the knees done, or because of work, there's a break. And if they don't do it now, it may be another couple of years before they can get to something. And the motivation you need for physical therapy is even greater than just for one knee.
Yes.
So we kind of have to screen those patients and ask them, are you sure you know what you're getting into?
So that's a great segue. Let's talk about the recovery process. Let's say you've gotten a surgery. How long does it take to recover? How long does it take to return to what some might call normal function? And if you would like to address, we did have a viewer question. How long will it take until I can drive again after a total knee replacement?
So that's a good question. Why don't you answer that part of that one?
So obviously you come in for surgery. You could discharge same day. You could go home the next day. Typically, you'll have home physical therapy for a couple of weeks before your first post-op checkup with the surgeon. So that means a physical therapist comes to you and works with you in your home. They start to immediately work on strengthening and range of motion, safety, walking, stair climbing. And then once they see the surgeon, they typically transition to outpatient physical therapy. That can last anywhere from 6 to 12 weeks. And we want to make sure that you've got full restoration of range of motion and strength and you can walk normally. So that's the goal.
So I'll start backwards with that.
Yeah.
So with full restoration and normal function, it takes time because if you really think about it, nobody rushes to get their hip or knee replaced. So that arthritis takes a while to set in, months, years, whatever you want to say. So the muscles can get weak and stiff, and it takes a long time for them to get that full function back. So to be normal, that's a very individual assessment, right?
Absolutely.
But to enjoy your new knee or hip replacement, I mean, it's a matter of days. We have patients who, when they first get up for the first time with a therapist, they talk about how the pain they were having before surgery is already gone, and that the surgery pain, which is like a more of a burning or achy feeling, is way more tolerable and controllable. So even by 2 weeks, when we see patients in the office, they're walking with some type of cane or walker, and they're overall doing really well, and they know they're getting better, and that gives them the confidence to continue the therapy.
Right.
All right, so we've got a couple minutes left. So Laura, as our program coordinator, I'd like to give you an opportunity to talk about the program. What makes the Holy Cross Joint Program so special, and why should patients want to get their care with us?
So we are a center of distinction, which means we are accredited by the Joint Commission for our joint program. So that means that our standards, our evidence-based practice, our protocols are all in line with a higher level of care. And everyone involved in your care is educated to what that means. We also are unique in that we have a dedicated unit and we have ortho-trained nurses. We have therapists that live on that floor. Basically, we have a dedicated gym. So when you're coming through the program, it's very systematic. And we also offer something unique to Holy Cross is a pre-op home safety assessment. We have partnered with Holy Cross Home Care, and we send a physical therapist to your house prior to surgery to kind of get everything in line so that you can return to a safe environment to recover in.
All right, so we've got about a minute left. So I do just want to see if we had any additional questions from the Facebook Live group. We did have one other question that came in. What if you have pain with ambulation, not at rest, but definitely have bilateral bone-to-bone via MRI?
So it sounds like this viewer is asking about bone-to-bone arthritis in the knees. And so more activity is going to make it hurt more. Again, it's the tolerance of the pain that makes you decide what to do. But I would definitely start with the pathway of things we've talked about, because if something along the pathway from PT to medication or bracing or using a cane lets you get by and feel comfortable and confident with what you're doing, that might be all you need to do. But if you try those things or you're just sick and tired of the pain, that's when you should really think about knee replacement.
All right. Well, thank you so much, Dr. Alam and Laura. It's
Sure.
been an incredible conversation today, very informative. I'm sure that everyone learned a lot. I know I did. But we're about out of time, so thank you everyone for tuning in today.